The coronavirus outbreak has brought dialysis services in New York to a breaking point. While government officials and hospitals scrambled to get their hands on ventilators, doctors also ran into a new crisis, a surge of coronavirus patients with kidney failure. Now, major hospitals across New York are reporting shortages of crucial dialysis equipment. For more on this growing crisis, let's bring in Dr. Michelle Mokricki. She's a professor of medicine at Albert Einstein College of Medicine and a nephrologist. That's a doctor who specializes in the kidneys at Montefiore Medical Center in the Bronx. Dr. Mokricki, please put this into context for us. How exactly is the higher demand for dialysis straining hospitals?
Well, so in early March, we had 0 coronavirus patients, and we quickly surged to over 2,000 coronavirus patients admitted to Montefiore Medical Center. We peaked April 14th. Unfortunately, about 14 to 15% of patients in the Bronx develop renal failure, and many require dialysis. Because we had this huge demand for dialysis, we quickly had a shortage of machines, supplies, and had to then adapt and use other strategies. The other strategies that are available are something called peritoneal dialysis that can be done up by the nurses on the floor as opposed to dialysis nurses per se, and other kind of dialysis procedures called continuous renal replacement therapies that are done in the intensive care unit. One other thing that contributed to this was that for coronavirus patients, you don't want to dialyze these patients in your dialysis unit because that exposes other patients to the virus. And so these patients require dialysis individually in their rooms and required one-to-one nursing. So it tripled our nursing demands very quickly. In addition, it also, at the same time, our nurses were becoming ill, and we had a shortage of nurses. So it was kind of a perfect storm.
Sure. Well, can you tell us more about what we've learned about the link between the coronavirus and the kidneys? What type of damage specifically are you seeing?
Yeah, so unfortunately, we're seeing very abrupt rise in the kidney toxin levels within a period of days. We've really never seen anything this severe, and it's felt to be due to either viral invasion in renal tubular epithelial cells, causing damage to the cells and leading to acute kidney injury, or due to other types of low oxygen levels in the kidney called hypoxemia. And so this all results in acute tubular necrosis and a very rapid rise in renal toxin levels, causing severe potassium levels, severe rises in acid levels, requiring immediate treatment.
And we also know that there's been a disproportionately higher number of African Americans and Latinos who need dialysis during the pandemic. Is there a particular reason for that?
That's right, Lana. So it is not a new, nothing new to the nephrology community that African American and Hispanic patients are at higher risk of kidney diseases. We've seen this in the HIV nephropathy case. We've seen it with other kinds of kidney diseases, including hypertension and other kind of proteinuria kidney diseases. African American patients and Hispanic patients have underlying genetic predisposition to develop kidney injury, a gene called APOL1. And so we're seeing a very different percent kidney disease in the Bronx, where our patients, roughly 74%, are either African American or Hispanic, versus even Long Island. In Long Island, a paper just came out where only 22% of patients are white on Long Island, and their risk of kidney disease, acute kidney injury, was threefold lower than what we're seeing in the Bronx. And the same holds true for what happened in China. The Chinese saw a much lower percent kidney injury than we did, and it's the kind of background genetic of your population.
Well, your hospital has also turned to a different kind of dialysis treatment in lieu of the shortage of specialized dialysis machines. Can you talk to our non-medical community a little bit more about this and how effective it is in treating the kind of damage that you're seeing in patients?
Exactly. So when we soon realized there was going to be a shortage of dialysis nursing staff dialysis machines, we rapidly expanded a new technique that we're using in our hospital called acute peritoneal dialysis. Our interventional radiologists, our surgeons inserted peritoneal dialysis catheters, and these are procedures that can be done at the bedside by floor nurses. My colleague, Dr. Ladan Golestane and Marianne Sorial have been really spearheading this, and I have to say they've saved lives. At least 30 plus patients in our hospital have received acute peritoneal dialysis who would otherwise we would not have been able to care for. Another thing that we've been doing is, again, doing more continuous renal modalities in the intensive care unit, and Montefiore has expanded the Great Hall, the Children's Hospital, to have sites where we can do these continuous renal replacement therapy modalities by the intensive care unit nurses. Another thing that has helped is that the perfusionists who usually run the cardiothoracic surgery procedures are staffing and helping with the intensive care unit nurses. So I have to say, at my hospital, everybody's been collaborating, contributing, and it's just been phenomenal. I've never been prouder to be at Montefiore.
Well, the innovation among medical professionals during this time has just been so inspiring. Hundreds of thousands of Americans have pre-existing kidney disease. So I'm wondering how you balance the demand from patients that regularly get dialysis and the patients who are in need of it now. I assume that your innovations have been essential in that, but is there more that goes into that?
Yeah, you're exactly right, Lana. So in the midst of this acute kidney injury, we've also had to care for our chronic dialysis population, and those patients are particularly at risk of developing infections. And so at the same time of treating acute kidney injury patients, we've been treating our end-stage renal disease dialysis patients who have become infected with the COVID virus. We've also had to screen very carefully in the outpatient units as to who is COVID positive and isolate them in cohorted units where only the COVID patients are dialyzing, so it doesn't put the other patients at risk who are sitting in the dialysis unit. So we've had to do a lot of things, both in the inpatient setting, the outpatient setting, and it's just been incredibly challenging. I can't tell you the surge of patients we've had and the collaboration among the subspecialties to try to care for every patient. And fortunately, I can honestly say no patient has been without the care they need in terms of renal replacement therapy. Originally, it was predicted that we were going to peak later in April, and we were going to experience a peak of 6,000 COVID patients. So far, we peaked on April 14th, 2,000 patients, and we're starting to see a decline in hospitalization rates. So fortunately, we never got to a point that we could not provide care for the patients that needed the care.
Well, it is inspiring to see not only the innovations that you and your fellow medical professionals are bringing to the field, but how you continue to treat not only the people who are affected by coronavirus, but also all the people who otherwise already need your medical assistance. Dr. Michelle Mokricki, thank you for joining us.
Thank you, Lana. Have a good evening.